Hello, everyone, and welcome to another Unfiltered production podcast. As you know, Cindy and I will get on these podcasts when we have a point that we need to rant about, and this is one of those times. We've been spending a lot of time looking at the 2023 proposed rule, and many of you have already read this, and many of you have already seen and heard a bazillion times that there's a proposed pay cut. We will not be getting into the math of that proposed pay cut, but we will be getting into the genesis of that proposed pay cut. Hence the title, Proposed Rule and Old Habits. Cindy and I were chatting this morning, and we came to the realization that once again, CMS is calling out therapy. So, Cindy, what is it that you think is going on in in therapy that CMS is aware of?
Well, I think they made it pretty clear, and this is kind of an extension of what they put in the proposed rule last year. And last year, they pretty much said, okay, we understand there's been certain things going on, related to the pandemic, and utilization of all services moved a bit. Therapy declined more than others. But it was kind of a we got our eye on you moment. And many of us were saying that last year. To see it come back now with, okay, it's still down. And if you compare some of it to the last one, nursing appears to be rebounding or not declining as rapidly, where therapy is clearly taken a less visit direction than they were pre-PDGM. And so, it's tough to look at, Sherry, and if people have not looked at the proposed rule, I know it's faster to have somebody give you the Cliff Note version. But especially speaking today to therapists, taking a look at those tables objectively, we have to come to a realization that trying to lay this all at the feet of the pandemic is not going to be, we're not going to be able to sell CMS on that. We just aren't. I mean, they're not going to believe that. Now, I might be in the minority, and Sherry got me riled up this morning and thus today's podcast. Because people, what I'm hearing is, well, there wasn't really enough time. It's all about the pandemic because PDGM was only live for what, 2.5 months at best in early 2020 before the bottom fell out. Um, I would say we have a problem with that. One, we know that in that window, before many of us even heard the term COVID, CMS was hearing about therapy reductions in our setting that were preempting the official start date of 2020 were going on in the last quarter of 2019, to the point where I had never seen one before. They had issued a MLN statement specifically calling out that therapy coverage criteria had not changed in PDGM, and basically saying patients that need therapy still need therapy, and that the payment for this was rolled into the PDGM methodology based on previous utilization. So basically saying if you said what they needed throughout 2019, well, that's what they tried to carry over to make equitable reimbursement based on that utilization. But the fact they even came out with an MLN means they were hearing something, they were seeing something. And it wasn't just CMS, Sherry, it was also Medicare advocacy groups. I remember standing at CSM around that time with Judith Stein, and she was talking about, beneficiaries reaching out to them being told that, their therapy isn't paid for anymore because of PDGM, or they're going to get less visits, or they were getting flat out discharged. Patients that had been on service for multiple episodes prior to this were suddenly being told or what they weren't going to get any more therapy. So I'm not saying everybody listening to the call today, we all participated in this kind of thing, but enough did that hit the radar. But again, you may say that was only 2 months. That's not fair. But I think we have to take a bigger view backwards on how we even got to January 1, 2020. Because prior to the year 2000, before we even got into prospective payment, when we were enjoying the days of being paid per visit as an industry, therapy utilization was low. It was not across the board tons of patients getting it in the home health space. And when they did, the average number of visits was about 6 or 7. So when a patient got it, they weren't getting a ton of it. So when they were building a prospective payment system and trying to get us away from visits, they treated therapy visits as a patient characteristic, just like they were going to take into consideration functional issues and vision and different things collected by the OASIS that were going to go into the magic formula to create payment. Because therapy was not a routine occurrence and especially not in large volume, they decided to treat it as a characteristic of the patient. To be fair, to say, okay, if not many patients get it, and when they do, it's like 6, then we need to set a bar by which if the patient needs more than this, then we have to provide some additional reimbursement for the agencies to be able to provide that level of care, which is why they landed on the original 10 visit threshold. Well, what happened after that? 6 kind of bit the dust, and we started doing all kinds of just over 10. And you could see the peak number of therapy visits go right to that 11 to 13 sweet spot. Go over the 10, don't land on 10, that might be too suspicious, but get right over it so that we could get that additional revenue. Now, right there, CMS could have said, okay, wait a minute, we think you're doing something sneaky, we're cutting you off at the knees, but they didn't. They looked at it and said, okay, maybe a single bar threshold is not the way to do this. Maybe we need to distribute the revenue over different groups of patients. So maybe this is now why we understand why there was a 6, remember, historical utilization, a 14, because the peak was 11 to 13. So 14 would be the next point at which it would be an anomaly for a patient to need that much. And 20 would be a rare occurrence. And that's where the higher dollar value was going to go in those unique circumstances. Now here we go again. Utilization shifted a second time. And all of a sudden, 11 and 13 kind of dropped off to become just over 14, and 20 or more became one of the fastest growing groups. So when I hear this isn't about PDGM. This is about the pandemic. There wasn't enough information. I think the pump had already been primed at CMS to be suspicious about how payment affects therapy utilization, because this is the third time in a row that this has happened. I don't think they needed more than 2 months. And I'm not convinced, Sherry, that if the pandemic hadn't happened, therapy use would have just stayed where it had been historically. But I'm going to put it back to you for a minute because I'm giving the history lesson and you can hear it in my voice, my level of frustration. Because what I hear is therapists playing the victim in this. The agency made me. The agency told me. The agency won't let me. This isn't my responsibility. What are your thoughts on that?
I think that therapists as a group, not all. I mean, we have some folks that are listening to this going, "This is not me that I'm hearing about," but they probably know somebody who's in the therapy field and home health that is in this situation. We look at different Facebook and Twitter pages and LinkedIn and Instagram, and we see posts that indicate that there's more people involved in this victim mentality when it comes to being told what to do. They complain that they can't get more visits for their patient. They complain that they're not being brought in on cases, and they also, on the reverse of that, complain because now they can do the start of care when all disciplines are ordered as a result of the pandemic. So it's kind of like I'm a victim to this, and I don't want to take any responsibility. Cindy, you and I and Dee have advocated for therapists to take responsibility from the minute we put this company together. And we know that there's one of the things that stands out about that is the website valuebeyondthevisit.com. We put that website together in 2013. We did that as a result of agencies just valuing therapists purely for those visits that reach the threshold and nothing more. We know that there's value to what therapists do in home health. The data says it. That's one of the reasons why CMS has involved therapy so religiously in their proposed rules since they started with PDGM and prior with PPS. We have to understand that the value of therapy in the home is there, but we need stewards. We need people that are going to take responsibility. We need folks that are going to stand up and take their DPT degree and use it in a way that's going to benefit the beneficiaries. I hate to get so blunt about it, but as a PTA, I'm going to tell you that I've always advocated for better supervision of physical therapist assistants. I've always advocated for evidence-based care, and I'm advocating again, take responsibility, be a part of the solution instead of bemoaning being part of the problem.
And what I'd add to that, Sherry, is I don't think all of the reduction was necessarily bad. I think that some therapists got very comfortable with the go ahead and see them some more. Not a lot of pushback unless you got, crazy and went past like 23. But the more we did, there wasn't a whole lot of scrutiny on that. I mean, I've listened to case conferences where the poor nurse is being told, I got a telehealth machine, get out. Are you done yet? Are you done yet? And encouraging the therapist on the same patient. Oh, you can go another week. You can do another cert period. You can keep going. And I'm not saying it was nefarious on the part of the therapist, Sherry. I think it was, well, I'm helping my patients. I like my patients. I like seeing them. We kind of lost track of coverage and qualifying criteria as well, and the infamous why me, why now. So we got to be in a comfort zone where writing 3-week whatever, nobody questioned it. Now, do I think that PDGM ratcheting it down and saying you get once a week is appropriate? No. But I think there needs to be healthy conversation about how much therapy does a person need and in what capacity. What about phone visits? What about someone who, I was reading a chart recently, Sherry, this person was recommended to go to a skilled nursing facility, declined to go to the skilled nursing facility. The family agreed to take them home. Numerous issues with ADLs, and the OT put down once a week. Really? And no aid.
No aid. That's a
Yeah.
big one.
So there's no aid, and OT is going to go once a week for this person who has all of these, I don't know, activities of daily living. What happens the other 6 days a week? So you look at it and say, higher acuity patients should be at a higher acuity of therapy. Do you need to have PT and OT at the same time? I think these are questions that we really didn't take on aggressively in an environment where it was kind of, insulated by the reimbursement piece. But now to just say, well, I would have done 3 times a week before, but 1 time a week is all the agency will give me, or all I have time for, or all that fits my schedule, is totally going to miss what exactly is best practice. How are we dosing our services? And I don't think these are easy questions necessarily, Sherry, because you and I see charts all the time where it looks like the same frequency and duration no matter what's wrong with the patient. And nursing does the same thing. We're going to do med teaching twice a week for X number of weeks no matter what's going on with the patient. We have to look at this because we are stewards of the benefit.
Mm-hmm.
And our kind of time of in the sun from a reimbursement perspective is gone. But I hate to see the pendulum go the other way with this. Well, now they won't let me. Now they won't let me. As you said, whether it's I have a DPT or I've got 30 years under my belt, I'm an autonomous practitioner, I am a therapist. Oh, but then they won't let me. They made me. They didn't do this. How informed are we about what the rules really are? Do we fully understand coverage criteria, including the provision, appropriate provision of maintenance therapy? Do we understand how we have to speak to homebound status? I mean, we're in a setting that has a lot of rules, and I'm not saying rules are fun, but do we know what they are? And are we practicing and providing the beneficiary the full scope of what they're entitled to?
Oh, 100%, Cindy. And I can't just, I'm going to echo what you're saying and agree with 100% with what you're saying. But I want to let people know CMS has gotten really, really good with the data. They understand, and value-based purchasing is going to take this to a whole other level as far as their ability to use the data to set the care and the costs of the care. So one of the things that was interesting about your historical lesson was we all, those of us that have been in this consulting capacity and been in leadership in home health for a very long time, the unintended consequence of increasing the visits to an average of about 19 or 20 when those thresholds were set up is that the data did not show a distinct improvement on the patients with those higher number of visits. The outcomes were the same with more therapy or less therapy. Just take that in for a second. Now with this data that they have for the first 2 months in 2020 and they look at the outcomes, I think that's going to tell us the same thing. And that's a little bit scary because the CMS has a leg to stand on when it comes to proposing a cut for 2023. And I'm telling therapists, and I'm calling this is a call to action. Take a moment and look at your practice. Take a moment and look at the practice of the therapists around you, and take a moment to comment on this proposed rule. The end of the comment period is August 16th. There's 3 or 4 ways that you can comment on this, and encourage your clinicians and your patients that enjoy having therapy services and enjoy having home health, period, to comment on this proposed rule and how it might impact them. CMS has to answer every single comment. They have to address every single comment. And I can't wait. If we actually got together as therapists and went against this cut, I think that we would have some pretty insightful responses from CMS. Don't you, Cindy?
Yes, and I think that that puts us in a unique position to spin the narrative away from we look like a big part of how we ended up with a behavioral adjustment. And the issue at hand is it is a severe behavioral adjustment.
Hmm.
And whatever other math that they're trying to put in here, it's a number that some have said if you run the numbers now, it could put a third of agencies out of business. And that's so hard to be okay with at the same time when we're hearing all this legislation to expand hospital at home and choose home, and people don't, the pandemic made it very clear they want to be at home. We're still the lowest cost provider. We still are where they want to be. And now you want to give us a insanely high payment adjustment. So we don't want therapists to mobilize to say, here's the reasons why therapy, got met. No, to step up alongside our nurses, our administrators, and all of it and say why this cut will hurt our patients. And it's not going to be constructive to say, well, the agency doesn't let me do more than 2 visits. Whatever. I need to step into this space and advocate for our patients, because if this kind of cut goes through, it could be devastating. And clearly we have dogs that are echoing that this is a call to action. They are calling you to action as well. But we have to do something. We can't just passively sit there and say, well, my administrator will probably write a comment, or APTA and AOTA, they're going to write comments, but those are like 2 comments. We need to see people involved in giving real life examples of how this kind of cut could hurt their access to very important clinical services.
Thank you all for listening. And Cindy, thank you for giving out some great information. And if you have any questions, please visit our website at www.valuebeyondthevisit.com and subscribe to our email blast. It'll have all the information that you need in order to formulate your comment and get it off to CMS before August 16th. Cindy, until next time,
I'm looking forward to it.
have a good day, everybody. Be safe.